So once again, thank you for allowing me to be here today, and thank you really to Debbie's Dream. I think all of the presenters and everyone here that's been touched with gastric cancer really realizes this is such a horrible disease, and we really need better advocacy and better coordination to really help fight this disease. So it's really my privilege to be here today to talk about integrating care. Like I said, my name is Matt Porembka. I am an assistant professor and the chief of surgical oncology at Parkland Hospital. So what is really my talk going to be about? And really it's about three main things. What is an integrative approach? What does it mean to have multidisciplinary care? And I know you guys have heard about this a lot today, and we're going to keep sort of banging this gong because it's one of the most important things about cancer treatment in general and also with gastric cancer treatment. Why is it not necessary? Gastric cancer is very complicated. We keep touching on this. It's a very variable disease, and knowing that and having experts that know that take care of you is extremely important. And what are we doing to try to make integrative care better, and what's sort of the forefront of personalized medicine in gastric cancer now? So we've come a long way towards integrative care. You know, the first reported case of gastric cancer was in 3000 BC and on a papyrus in Egypt, which reported an obstructing stomach mass. Since then, in the 1800s, we recognized that at that time, gastric cancer was the #1 cancer killer, and that was really sort of centered in Italy at that time. And then 1881 was the first successful gastrectomy for cancer. Only about 50, 60 years ago, we started actually integrating different kinds of therapy together to try to make it the most impact in this disease. So if we put integrative care together in a sentence, what would it be? It would be an approach to care that considers all aspects of the individual patient and the entire patient care process throughout the entirety of that patient's disease course. So a lot of times when we think about integrating care, we really think about the cornerstones, meaning medical oncology, surgical oncology, radiation oncology, and gastroenterology, actually just treating the tumor. But treatment of that tumor is only a very small part of what the patient experiences in their cancer treatment. So from the patient's perspective, one of the spokes is treatment. But then I think we all appreciate that when I appreciate it, when I treat a patient with cancer, I'm not just treating that patient, I'm also treating their family. So we have to appreciate how that cancer and how that cancer treatment affects the patient's family too. And then we also talk about how to treat their symptoms, not just their tumor. How to really schedule appointments and coordinate their treatment in such a way that it doesn't actually have a negative financial impact on their life, and make sure they continue with their livelihood as best as they can during and after treatment. And then finally, like we just heard, nutrition is a very key part of cancer treatment also, and it's something that we need to integrate most certainly into our plan. Another part that is becoming more and more salient is also the genetic risk counseling that goes with treating cancers, as we're identifying that patients with gastric cancer and other cancers have a predisposition for their family members to have developed cancers also. So integrative care, why is it important? Well, really, the bottom line is that multidisciplinary care, which is all of these different parts, palliative care, radiation oncology, surgical oncology, radiology, gastroenterology, social work, infusion, nutrition, when you put it all together in a multidisciplinary package, it is much greater than the sum of its parts. And that's sort of what we want to bring to the gastric cancer patient, is everything in one package. And like I said, this needs to occur during the entire spectrum of care, from the point of diagnosis to their staging, to treatment, and then beyond treatment, when they're cancer-free, then to surveillance. So as we all know, and we've talked about, and you're going to hear some of the same themes from the other speakers, and I'll echo those again, gastric cancer is complicated. You know, it's not just one disease. And we have a lot of different ways of segregating this cancer into different types of cancer that respond differently to treatment and actually need to be treated in different ways. Under the microscope, we see different types. Tumor location also we see differently. Those tumors that are near the connection between the esophagus and the stomach behave differently and require different treatment with radiation and chemotherapy, where other tumors sometimes in the other parts of the stomach don't require radiation as often. We know that gastric cancer behaves differently in different race and ethnicities. We see different outcomes, we see different responses to chemotherapy. Then also, as we learn more and more about the genetics of these tumors, we see how different predispositions arise for different patients with different mutations and different tumor profiles. And this is just a good example of how it is different across the world. I know it's a slide, but essentially the heat map is looking at incidence of various cancers and mortality, and stomach cancer is the fifth one down. And it's very prevalent in different parts of the world, and it actually kills at a different rate in different parts of the world, which really suggests there's probably an intrinsic ethnic bias for the gastric cancer in different races and ethnicities. And this probably relates to risk factors, environment. Being in Texas, we have to really comment on the fact that barbecue has now been realized as a carcinogen by the WHO. As well as H. pylori. So when we talk about integrating care, this really can happen anywhere along the spectrum between diagnosis and surveillance. And just, I think, as a fundamental principle, what are the key components of cancer care? One, we need to name the tumor, which is the biopsy. Then we need to stage it, and that's really determining how far the cancer has spread. Then we treat it, and then we go into surveillance. Most patients, when they actually get detected with gastric cancer in the United States, are diagnosed because they have a symptom. This is unlike in other parts of the world where there's screening programs. So most often when people are diagnosed, they haven't been introduced to the multidisciplinary team yet. They're coming from their primary care doctor or their emergency room where they have an endoscopy that's abnormal or a CT scan that's abnormal. And you can see things like this sometimes, a highly abnormal thickened stomach on the CT scan or a gastric tumor endoscopy, then that yields a biopsy, and that essentially names the kind of cancer we're dealing with. So that's the first step. And then the second step is really the staging of the cancer. And this is really where I think it's important that someone with gastric cancer gets connected with that multidisciplinary team, because staging is really dependent on where this happens. It requires advanced CT scanning, advanced radiologists who know how to look at them, excellent gastroenterologists who can accurately stage that tumor with ultrasound if needed. And a lot of times it also requires the hands of a surgeon to actually do a diagnostic laparoscopy to make sure that the disease hasn't spread. And now kind of go into this a little bit further, and it looks like the slides haven't translated that well, but there's three different types of staging, and when we look at this, the first picture is local, meaning that tumor is still confined to the stomach, and that's the earliest stage of cancer that we can sometimes only treat with surgery. Then there's regional disease, where it's spread from the stomach to the lymph nodes around the stomach, and that's treated with what we call multimodality therapy, using surgery and chemotherapy and sometimes radiation. And then there's finally distant disease, and that's when it's spread outside of the stomach to other organs, to the lining of the peritoneum, which is the lining of the inside of the abdominal cavity, and that's that top picture there. That's where laparoscopy is a really useful test to see that, because it sees the lining that can't be really detected on traditional CT scan. Or we can see distant disease in the form of liver metastasis, liver tumors, or lung tumors. So really the importance of accurate staging, really, it determines the optimal treatment. Without accurate staging information, the patient may not be treated in the right way. So that staging is really the hallmark of sort of how we guide our treatment. And then secondarily, it really informs provider and patient expectations on what's going to happen throughout their treatment and afterwards. So how do we assure that we get the appropriate tests? Is it a CT scan? Is it a laparoscopy? Is it an endoscopic ultrasound, PET scan? I think that's really when we need to make sure we have that multidisciplinary team together. And we'll talk about that a little bit more. And when we put all that information together, we can give you a very complicated stage. But when it comes down to it, it ends up being either an early stage cancer, a middle stage cancer, or a late stage cancer. And when we look at this, we really see that the kind of treatment that someone will be recommended will be based on what that stage is. So the real hallmark of integrative care is to bring the experts to the patient. Don't make the patient go to all the different people. Bring all that care into one spot. And really there's four hallmarks, I think, of modern cancer care, and I think they're the 4 C's, which are conferences or tumor boards, clinics, in multidisciplinary clinics where you have multiple different providers in one setting that can easily help the patient in that one visit. care pathways to streamline the care, and then also collaboration to further research and development of better care. So I think the first is a tumor board, and some of you may not be familiar with what a tumor board is, but it's essentially a conference, and the patient is not usually at this conference, but we present the data, the imaging scans, the staging scans, and at one location we have a medical oncologist, a radiation oncologist, a geneticist, a gastroenterologist to review that, to come up with a plan together. It really helps to see if that radiation will be recommended or not recommended, what kind of chemotherapies they would get, are there trials available for that patient. So that really helps sort of the planning stages of really giving the best care, to multidisciplinary care to the patient. And then the second is multidisciplinary clinics, and I'm very fortunate to practice in an environment where we have access to multidisciplinary clinics. Within my clinic, I have a registered dietitian who can help educate my patients before chemotherapy, before surgery, after surgery. I have a medical oncologist who's right down the hall. If there's any questions about their upcoming chemotherapy, they can be answered right at that moment. We have access immediately to a social worker if there's issues with transportation that bring all of this together, as well as genetics. So I think multidisciplinary clinics is really focused on the patient to make sure that they don't have to go through multiple visits to get the care that they need. And then basically care pathways. This is sort of highlights one of the things that I did when I got to Parkland Hospital. When I got there really wasn't a home for gastric cancer. It was kind of distributed all amongst the different specialties. We saw that the care was very serial, which means a test happened, we waited for the result, another test happened based on that, and a referral was made. And you see that this procedure, this process was stretched out over multiple days. So looking at the data retrospectively, we saw that a patient would have an endoscopy, the pathology would take about 8 days to come back, to get acted on, to get the referral in, to get the appointment made, to get the port placed, to get the staging scans, to finally come see me, and then start their chemotherapy. We were taking over 75 days to get all that done, and that was just way too much. So essentially what we did is we decided that the home of gastric cancer would sit with sort of my group in surgical oncology, so the gastroenterologist then would call as soon as they had any concerning finding on scope, and then we would facilitate that treatment by making sure we get pathologic confirmation in an expeditious fashion, and then order the staging scans that were appropriate for that patient and that tumor, arrange the diagnostic laparoscopy, which was really critical in these more advanced stage cancers that I see. Essentially get the port in, the referral, and we were actually trimming down the time from diagnosis to treatment by over half. So I think this really highlights, by actually having a care pathway, you can really develop parallel efficiencies. You have fewer unnecessary tests, more accurate staging because it's being done by the experts, as well as more consistent treatment management. So finally, the final C of gastric cancer treatment and multidisciplinary care is collaboration. And I just picked sort of one of our collaborators that we have because it really sort of highlights how, to make progress in this disease, you have to really collaborate widely. And we have a collaboration with a group in South Korea where we tried to develop essentially a genetic risk score, looking at the tumor to see if we could predict how patients were going to do. So we used their samples and our materials, and we put together a genetic risk score, which basically showed that based on the tumor and independent of anything else, we could segregate patients into a low risk group, a medium risk group, and a high risk group that was a continuous variable, meaning that a score of 10 was higher than 1, and that predicted survival independently of stage, receive of chemotherapy. So in closing, integrative care, what is it? Well, it's about focusing on the patient and bringing all the resources we need to deal with this very difficult disease to them, in hopes that we can actually impact the disease and make a difficult process easier. So I really appreciate the opportunity to be here, and I'll be happy to answer any of your questions.